Hello everyone, I am Ms. D. Rajeshwari, your pediatric faculty. I welcome you all to KNO Academy. In this session, we are going to see part 3 of highly important MCQs in pediatrics exclusively for your upcoming NORCET, ESIC and RRB exams. Let's quickly move into the session. Here is the first question, which is cognitive development theory is given by. So here are the scientist names they have mentioned you, and we have to find out who is the author of cognitive development theory. Options are like Ivan Pavlov, second option is Jean Piaget, third option is like Maslow, and fourth option is Sigmund Freud. So the right answer here is option B. So I'll just write the theories and who have invented the theories here. Let's see the first theory, which is psychosexual development theory. Psychosexual theory. Second one is intellectual or cognitive development theory. This is the second theory. Third one, moral development theory. Fourth one is psychosocial theory. Psychosocial theory. So let's see the first option here. The psychosexual theory was written by Sigmund Freud. The second one, intellectual or cognitive development theory, was done by Jean Piaget. Third theory, which is moral development theory, was written by Kohlberg. Kohlberg. Fourth one, psychosocial theory. It was developed by Erikson. So these are the four important theories which we are going to see in growth and development of children. So these are the author names. Here the given question is cognitive development theory, or sometimes they can even ask you like intellectual development theory. And the right answer here is option B. Answer is option B. So let's see the next question. Here is the question. To decrease the bradycardia in children during endotracheal intubation, succinylcholine is the drug which is used for the following agent. So, along with succinylcholine, which all the other drugs can be given to control bradycardia in the children whenever we are doing endotracheal intubation. So, let's see the options here. Option A is epinephrine or adrenaline. Second option is atropine. Third option, lidocaine. And fourth is none of them. Here, first let me tell you the concept so that we will find out the answer here. Usually, bradycardia in children, especially during intubation, in endotracheal intubation. Bradycardia occurs because of vagal stimulation. So what we have to do is we have to mix the drugs, like we are getting succinyl choline plus we have to give a drug which is going to control bradycardia. We are mixing atropine with that. Then we need to know why only atropine, why not the other drugs here. So the reason for giving atropine we will see first. Atropine is usually anticholinergic drug which blocks the action of vagal nerve on heart so that it prevents bradycardia. Okay, so this atropine is going to act on heart like controlling the stimuli of the vagal nerve that thus so it will be preventing the bradycardia during endotracheal intubation. Here the other options are first option is adrenaline and last option we are seeing here is lignocaine. So we'll see what is the use of adrenaline and lignocaine. So if you take adrenaline, it is usually a potent vasodilator. Sorry, 1 second. It's a potent bronchodilator and acts as a vasopressor. Okay. The last drug what we have seen in the other option is like lignocaine, which is a local anesthetic drug. So mainly they have asked you why bradycardia is occurring in a child whenever we are giving endotracheal intubation, that is because of vagal nerve stimulation. How to control that kind of stimulation is we have to combine the succinylcholine drug along with the atropine. The atropine action is it is an anticholinergic that blocks the action of vagal nerve on the heart so that it will be preventing bradycardia. The right answer here is atropine. For simple, this is a vasopressor. This is an anesthetic. This atropine is going to shoot up the heart rate. It is not definitely not going to cause bradycardia. So in this way, we can find out the right answer, which is atropine. They have asked you, they have given you a hint here. They are giving, firstly, they are giving succinylcholine. So next we have to see an anticholinergic drug, which is atropine. So let's see the next question. A nurse is performing a physical examination of an infant. She notes abnormally low set ears. So, this finding is usually associated with which abnormality? The options are renal anomalies, B is tracheoesophageal fistula, C is congenital heart defects, and D is tetanus. So, if you see low set ears, usually this is seen in Down syndrome as a one such characteristic feature of Down syndrome, but it is not seen in congenital heart defects or tracheoesophageal fistula. So, if at all they have given you Down syndrome, that will be the right answer. Or the second right answer is any renal abnormalities. So the right answer is option A. It is not tetanus or TEF or congenital heart disease. The right answer is renal anomalies. In renal anomalies, we are going to see abnormally low set years in the infants. So let's see the next question. A nurse should expect a 3-year-old child to be able to perform which action? So here options are stating about the developmental milestones. The first thing is roller skate, second is jumping rope, and the third option is riding a tricycle. Fourth option is tying the shoelace. So we need to know at 3 years of age what a child can perform. Simple answer, at 3 years, child should be able to ride a tricycle. Tricycle, 3 and 3. Okay. Generally, this jumping rope and all is seen at 2 years. This is seen at 2 years. Riding tricycle at 3 years. Skating will be like for at 3 to 5 years of age, and tying shoelace it will be like around 6 years. So the right answer is at 3 years of age, the child should be able to ride a tricycle. Answer is C. So let's see the next question. Nurse discussing why children are predisposed about otitis media. The nurse should mention the significance of which anatomical feature. So whenever we are discussing about the otitis media with parents or with the family members, so about which anatomical feature we are talking about. Otitis media is caused where? So if you see options given are tympanic membrane, outer auditory canal, nasopharynx, and eustachian tube. So let's see the image given here. If you see the image, you will identify where is the presence of nasopharynx. Here is the nasopharynx. From nasopharynx, there is a connection called eustachian tube, and which is connecting the middle ear here. So middle ear is connected to nasopharynx by a canal called eustachian tube. So the answer is eustachian tube. So we'll see about eustachian tube here. This is a canal. It is a canal that connects the middle ear with the throat area. Usually, this eustachian tube helps to equalize the pressure between outer ear and inner ear. Children often get infections than adults because eustachian tube is short, narrow, and more horizontal than adults. So if you see eustachian tubes in the children, it is compared to adults, which is very short, narrow, and horizontal. That's why many of the infectious organisms will easily enter into the tube and it is going to cause some infections in the children. So that's why if at all we are identifying any kind of ear infection, that might be happen because of the anatomical feature called eustachian tube, where you are going to see the pathogen getting entered into the ear canal. Okay, so that is about the eustachian tube. So let's see the next question. Which finding is the earliest sign of improvement in a child with acute post-streptococcal glomerulonephritis? So, if we have to see what happens in post-streptococcal glomerulonephritis child. So, typical signs and symptoms of the child who is having post-streptococcal glomerulonephritis are, it is like more often nephritic syndrome features. Same as nephritic syndrome features. So, what are those nephritic syndrome features? Mainly hematuria, oliguria, hypertension. Last is edema. So, these are the main features that we are going to see in a post-streptococcal glomerulonephritis child. But if you have to see as an improvement in a child condition, this thing should not happen. Okay, like edema should be resolved, hematuria should be resolved, oliguria should be resolved, and hypertension to be resolved. Then only the child will be having some improvement in that kind of infection. So let's see the options here. The first option is increased creatinine level, which is a worsening symptom. So this is not the option. The second option is increased appetite. So appetite is not affected here. The third is increased urine output. Definitely it's a good sign because oliguria is the feature of glomerulonephritis. So if the child is improving in the condition, then definitely increased output is seen. So this is the right answer. Last option is decreased diarrhea. Diarrhea is not seen in this condition. So the right answer here is option C. So let's see the next question. An infant having vomiting and diarrhea lasted for 2 days. On assessment, the nurse detects dry mucous membrane and lethargy. What are the other suggestive features of a fluid volume deficit? So, in an infant, okay, whoever is crossed 1 month of age to 1 year, okay. So, in this child, they are asking you the features of dehydration. So already they have given you few features, which is like dry mucous membrane and lethargy. That itself is going to tell you that the child is in severe dehydration. So what are the other features? So in severe dehydration, definitely you're not going to see increased BP. BP should fall down. Okay. So the low urine specific gravity, it has to increase. Again, that is not an option. Third option is a sunken fontanelle, which is a prominent feature in dehydration. So that is the right answer. The fourth option here we are seeing is decreased pulse rate. No, pulse rate will increase. So the right answer here is option D. So let's see the next question. An 18-month-old child has been brought to the emergency room with irritability and lethargy over 2 days, and you are even seeing dry skin and increased pulse rate. So, based upon the evaluation of these initial findings, the nurse would assess the child for what all the additional features. So, all these features are defining the symptoms of dehydration, or we can even call it as fluid volume deficit. So, we have seen in the last question about the signs of dehydration. So all these signs are mentioned here. Typically, the answer is option B. Let's see the next question. Which of the following signs and symptoms would observe in a child who is diagnosed with laryngotracheobronchitis? So we need to know about laryngotracheobronchitis. Other name for it is Croup's disease. So in Croup's disease, we are going to see prominent two symptoms, which are barking cough and presence of stridor. Okay, so these are the two important features that we are going to see in the Croup's disease. So let's see the given options here. High fever. Fever might be there, but again, it is not going to show the laryngotracheobronchitis. Second is slow respiratory rate. Respiration might be irregular, but not against slow respiration. Third is predominant stridor on inspiration. Yes, this stridor is going to uh, mimic the barking cough. Okay, so the right answer is option C, predominant expiratory wheeze. It is not seen in this condition, it is seen in asthma and COPD. Okay, so the right answer here is option C. So let's see the next question. The mother of a 3-year-old with esophageal reflux asked the nurse what she can do to reduce the baby's reflex. The nurse should tell the mother, like in what way we have to control the baby's reflex whenever we are feeding, and the child is having exclusively esophageal reflex. Let's see the options. The first option is place the baby in supine position with head and getting elevated. Supine position is not at all advised in this case. Okay. Next option is burp the child frequently. Frequent burping throughout the feed. That is really an important advice to be given to a mother. So this is right answer only. Let's see the third option. Feed the baby only when he is hungry. It's not the option here. And the next option is burp the child after feeding completed. No, we can't wait till the feed is getting completed. Why? Because whenever we are giving the feed, when the food is entering into the tract itself, there is the reflex happening. So while feeding only, we have to start doing the burping for the child, and the burp also should be so frequent so that the reflex cannot happen all of a sudden. Okay, so the right answer is option B. So let's see the next question. Which achievement best characterizes the physical development of a 3 months old infant? So, what a 3 months old child can do. The options are the ability to lift the head and chest, from a prone position. Option B is the ability to roll over intentionally. Third option, a strong tonic neck reflex. Fourth option is a strong Moro reflex. The right answer is option A here. Okay, in this, because the child will be getting head holding. Okay, little bit head holding will happen. Because of that, whenever the child is in prone position, the child will lift the head and chest from the prone. So that is the physical development milestone which you are going to see in 3 months child. If you see the B option here, rolling over. So rolling over will happen from 4 to 7 months. It's not at 3 months. Tonic neck reflex will disappear by 5 to 7 months. Otherwise, this tonic neck reflex, Moro reflex, these reflexes will come by birth itself. But if you see the reflex getting disappeared, it happens by 5 to 7 months, tonic neck. And Moro reflex by 2 months. It has to go. Okay. So they have asked you about 3 months child, which will happen like head and chest elevation from the prone position at 3 months. Right option is A. Okay. Next question. A nurse in a delivery room is assisting with the delivery of a newborn infant. After the delivery, the nurse prepares to prevent heat loss in the newborn by. So here they have just told you how to prevent the heat loss, by which method and all. It is not specified. For each and every method, there is a technique how to prevent the heat loss. Okay, just after the delivery, how to prevent the heat loss is: options: drying the infant in a warm blanket, closing the doors to the rooms and start cooler. So we are not putting cooler here. Turning on the overhead radiant warmer, and yes, radiant warmer we will put, but how to prevent heat loss very immediately after birth. So it is not immediately, it will happen eventually. Warming the crib. First we have to preheat the warmer and then only we will place the baby in the warmer. These two options are regarding radiant warmer only. Before putting the baby into warmer, we can dry the infant by covering with a blanket. So the right answer here is option A. Suppose if they are specifically asking you evaporation method, conduction method, convection method, so based on this, each and every option will be varying. But they have not asked you any kind of method of evaporation kind of thing. They were asking you simply how to prevent the heat loss in the newborn immediately after birth. But first we have to dry the infant and then we have to put on the warmer and then we have to form the child and we will resuscitate the child. So otherwise, the answer is option A. So let's see the next question. A nurse in a newborn nursery is performing an assessment of a newborn. The nurse is preparing to measure the head circumference of an infant. So the nurse would most appropriately. So here they are giving you the options how to measure the head circumference. So if you see the image given here, so you'll come to know how to measure the head circumference of the baby. First of all, head should be in the Frankfurt plane. In this Frankfurt plane, we have to measure, the measuring tape should run around the occiput region and it should be just above the supraorbital ridges or right above the eye. So above the eye level, covering the occiput, we are putting the tape and we are measuring the head circumference in the Frankfurt plane. So if you see the options given here, place the tape behind the infant's head, wrap around the ear and infant mouth. No, it's not about mouth. Place the tape under the infant's head. Okay. Wrap around the occiput. Occiput is the right measurement and measure above the eye level. So this is again good option. So option B is right here. Let's see the third option. Place the measuring tape under the infant head at the base of the skull. No. Wrap around to the front just above the eye. No. Because here we are not concentrating on the base of the skull. I mean, the occiput will be covering, but we have to see specifically that it should be above the supraorbital ridges. So in this, above the eyebrows if they tell, but comparatively occiput should be there in the options. Okay, if occiput is covered and it is covering the ridges above the eyebrows, just above the eye level, so that will be the right answer. Okay, the answer is option B. So let's see the next question. A nurse is providing instructions to the mother of a newborn with hyperbilirubinemia or jaundice, which is and who is being breastfed. Okay, the nurse provides which most appropriate instruction to the mother. So already the child is having jaundice, but still child is taking breastfeed. So what advice we can give to the mother? Stop the breastfeeding. So we are not stopping the breastfeeding for the child. Administer NG tube. There is no logic giving feed through the NG tube also. Switch to bottle feed to the baby for 2 weeks. Never they are advising for any child to give bottle feed. Continue to breastfeed every 2 to 4 hours. Okay, so this is the right answer. We are not going to stop the breastfeed for the child, whoever is having jaundice. The appropriate treatment for the jaundice child will be two options. For jaundice, mainly phototherapy and exchange transfusion can happen. Again, depending on the bilirubin levels only, we are going to opt for these two options. If it is less comparatively, then they will just advise the mother to feed the baby continuously. Okay, so the right answer is option D. The next question, what is the purpose to administer vitamin K injection to a newborn infant? So why we are giving vitamin K injection immediately after the delivery? Infant needs vitamin K to develop immunity. It is not for developing immunity. Vitamin K will provide infant to be our from being jaundice. No, it is not protecting against jaundice also. It have sterile bowel and vitamin K promotes the growth of bacteria in the bowel. Also no. Just for controlling the bleeding disorders in the children, we are giving vitamin K. So the here right answer is option D. Next question. A newborn with upper score of 1 to 4. Planning for the admission of this infant, the nurse highest priority should be. So if the newborn's upper score is from 1 to 4, so what we are going to do? Let me tell you the options here. What happens for 1 to 4 and all. 1 to 4 is high risk. 4 to 6, if you see, moderately risk. Moderate risk. Greater than 7 is like normal or very less risk we are going to see. So if you see here, 1 to 4 is showing high risk. So definitely we have to resuscitate the child. Okay. And the options are like connect the resuscitation bag to the oxygen outlet, set up the IV line for dextrose. We are not going to give dextrose for this child. Warmer, no. Inform the parents, no. The right answer here is option A. Answer is option A. So let's see the next question. What is the primary critical observation for upper score? So A, B, G, A, R. Appearance, pulse, grimace, activity, respiration. So these things we have to see in Apgar. We are not checking fever. We are checking heart rate. We are not checking respiratory rate. We are not even checking presence of meconium. So the right answer here is option B. Next question here. What are the essential symptoms of kwashiorkor? Okay. So the essential features. Here are the options. Retarded growth. Growth is definitely retarded. Yes. Edema will be there. Edema is a classic feature of kwashiorkor. Yes, it is present. Mental changes. Obviously, there are mental changes in the child. All the given three options are included as symptom of kwashiorkor. So the right answer here is option D. The next question. Within 3 minutes after birth, the normal heart rate of an infant may be between. So they are asking you about the heart rate of an newborn child. So the right answer here is 120 to 160 beats per minute. So within 3 minutes, you are going to check the heart rate this much. The answer is option B. Definitely not less than 120 or not more than 160. So it will be like 120 to 160 beats per minute. The next question, expected respiratory rate of a neonate within 3 minutes. In last question, we have seen heart rate. Now we are going to check the respiration rate. The respiration rate for this child will be 60 breaths per minute. As high as it is the highest limit they are asking. as high as 60. So the answer is option B. So the next question, what is the respiration rate of a healthy newborn? Healthy newborn, what will be the rate? Just now we have seen it will be around 60. Okay, it is not 40 actually. It will be from 30 only, 30 to 60. But how is the respiration we have to see? Whether it is initiated by the chest wall or it is initiated by the diaphragm of the abdomen, or how we have to know. Usually, the healthy newborn child respiration will happen by abdomen only. Why? Because the rib cage is not fully developed. So abdominal respiration. So in this chest wall question, easily we can ignore. It is not chest wall. So 1 and 3 options are wrong. Next options are like rate. Rate, I told you it will be 30 to 60. Here they have mentioned only 20 to 30, and that too it is a deep. This is not an answer. The right answer here is irregular respiration will be there. Answer is B, irregular abdominal respiration 30 to 60 per minute, and it sometimes becomes shallow also. Okay, we can never tell it as a normal regular beat respiratory rate, because for newborn it will take some time to get adapted to the external environment. So there will be some irregular movement in the respiration. So the answer is option B. So let's see the next question. What is the planning of care to help limit the development of hyperbilirubinemia in the neonate? So how to reduce the risk of getting neonatal jaundice? For that, options are supplementing the breastfeed with glucose. We are not adding any glucose to breastfeed. Substituting the breastfeed. No, we should not substitute the breastfeed also. Monitor for the passage of meconium each shake, and instituting the phototherapy for 30 minutes every 6 hours. Before even the child is getting hyperbilirubinemia, we cannot put the child on phototherapy also. Okay, this is the treatment method only. But how to reduce the risk is like we have to exclusive breastfeeding, plus monitor the stool. So these two things we have to follow in order to control, okay, the bilirubinemia in the neonate. The right answer is option C. Let's see the next question. The nurse observes the neonate to have acrocyanosis. Okay, just 2 hours after the birth. So which of the following nursing action should be performed initially? So if you see the newborn assessment, acrocyanosis is usually seen in the newborns, and which is a normal feature. Here, nothing to worry. So, okay, so that if at all the child is having the peripheral bodies and all, we need not worry much, because it will get resolved within few hours. So no need to worry. The options are like notify the physician of the need of a cardiac consultation. No. Immediately take the newborn's temperature. No. Do nothing, because acrocyanosis is normal in the neonate. This is the right answer. Activate the code blue for emergency system. No, cyanosis will resolve by its own. So the right answer here is option C. So let's see the next question. What is the common complication in a neonate of diabetic mother? So these diabetic mothers who is having diabetes during the gestational period, so there is a risk of post-term pregnancy. Okay, like above 42 weeks. So what happens? Child will be very big. Child will be big, and risk of hypoglycemia is seen. Mother will have increased sugars, but child will have less sugar levels. So that is the main complication we are seeing in a neonate of a diabetic mother. It is not nitrogen loss or anemia or marasmus. It is hypoglycemia. So the answer is option B. So let's see the next question. Which physical finding is expected in neonate just after birth at 42 weeks gestation? Just now I told you 42-week gestation is nothing but postpartum pregnancy. In postpartum baby, they first of all the baby will be big size. Okay, so it is not microcephaly. Okay, and lanugo or vernix we are seeing in preterms. It is seen in preterms, not in postterm babies. In postterm babies, we are going to see desquamation of epidermis. This is the main feature of postterm babies. So the answer is option B. Why? Because dry, peeling, and loose skin will be present. And we can even see overgrown nails also present in the postterm baby. That is about the postpartum baby. Let's see the next question. Which condition would the nurse anticipate in the neonate if neonate's maternal history of magnesium sulfate during labor? So why they have given magnesium during labor? So usually this magnesium is given to prevent preterm delivery and also to treat eclampsia. For these two reasons, they are giving MGS4 during labor. But again, we can anticipate the side effect of MGS4 on baby, like baby might be in risk, increased risk of hypotonia, respiratory failure, feed intolerance, hemorrhage, cardiac failure, and patent ductus arteriosus. These are the risks that we are going to see in the neonates whenever the mother was given MGS4. But if you see the options here, they have asked you like tachycardia, respiratory depression, hypoglycemia, and septic shock. So septic shock is not going to happen. No kind of infection is entered before labor here. They have. I told you there is a risk of respiratory failure. So depression, respiratory depression will be the right answer. Answer is option B. Tachycardia also is not going to happen. Hypoglycemia also no. The right answer is respiratory depression. Let's see the next question. Which of the following common complication in a neonate of diabetic mother? Common complication they have asked you. So if you see, the child will be having macrosomia, yes. Respiratory distress can also be seen, but not mostly. Most common will be like big head only. Pneumothorax, no. Microcephaly, no. The answer is option A. Okay, here it might not be the complication, it is the feature. Okay, but if they had given MGS for 4, then there will be respiratory depression. So in question, if they have given you MGS to 4, then the option will come like distress. If in the question they have not specified anything about MGS to 4, just about the diabetic mother neonate, then you can see the classic feature called macrosomia. The answer is option A. The next question here is, what is a neonatal capute succedaneum? So the two terms we need to know, and capute and cephalohematoma. So what is capute and what is cephalohematoma? So first thing is option, it is a collection of blood, cephalohematoma. So blood in the skull region. So in capute, we are not going to see blood. So this is not an option. Abnormality of the cranium. It is not like born with some kind of feature. While delivering the baby, this is going to develop. So this is again not an abnormality. It involves swelling of tissue over the presenting part of the presenting head. This is the right answer for capute. So let's see the image given here. If you see this image, you can clearly see there is edema over the scalp region. The scalp swelling is present due to the fluid accumulation. It is not clearly blood, it is only fluid accumulation, which is seen during delivery, but it will resolve after the delivery. But if you see cephalohematoma, there is blood clot under the scalp bound by suture lines. This will take weeks or months. This will take only days to resolve. It will take only days for capute, but it will take weeks or months for cephalohematoma. In capute, you are just going to see only edema, like fluid accumulation over the scalp. But in cephalohematoma, this kind of feature will be there. Generally, like when we put a cap over the child head, how it will be evenly sitting. So evenly you can see fluid accumulation. But in cephalohematoma, only for one side you can see the swelling, and that too it is accumulated with the heat. So this is the uh, pictorial representation of these two terms so that you can easily remember. So let's see the next question. The most common neonatal sepsis and meningitis infections seen within 24 hours after birth is caused by. So they are asking you the causative organism for neonatal sepsis. As I told you earlier, the most common causative organism for neonatal sepsis and meningitis is group B beta hemolytic streptococci. So this is the main causative organism. Answer is option C. So let's see the last question in this session. Which of the following are important for umbilical cord care? So after the delivery, or how to take care of the umbilical cord. Cover the cord with petroleum jelly after birth. So actually, once we clamp and cut the cord have to be in the open air. Okay, we can dry because after like seventh day to 10th day, it will dry and the cord will fall down. So nothing to do with the cord. Suppose if the child is very preterm, or if the child is having any kind of bleeding disorder, if there is any plan for any transfusions, at that time we can preserve the umbilical cord. Otherwise, no need to preserve the cord and all. So just we will keep it dry and open to air. So the right answer here is option D. We should never wash the cord with soap and water, or we should not apply any hydrogen peroxide, or we cannot apply any petroleum jelly for the cord. Just we have to the clamp should be very tight to the cord, and it should be dry and open to air. The right answer is option D. So this is the end of the session. We have seen some 30 important MCQs in this session. Let's see with a few other important MCQs in the upcoming sessions. I hope you understood this video. Thank you.